So the next speaker this morning is Dr. Adriana Tremoulet, who is our newest addition to the Kawasaki disease clinical research team. Many of you had Audrey as your doctor when you came to Children's Hospital. We're thrilled to have her working with us. And she's going to be speaking about the treatment and about a very important issue, which is how we're going to prevent children who are still having late diagnosis or even worse, missed diagnosis, and how we're going to change that for those children. So please welcome Dr. Adriana Tremoulet.
Good morning, and it's a pleasure to be here. Bienvenidos a todos los que vienen desde México y de otras partes. I'll be speaking in English today, but I'm more than welcome to be available for answers in Spanish. Para cualquiera padres que quisieran hablar español durante los momentos que tenemos después de la conferencia, por favor, hablen conmigo. So today what we're going to be speaking about is current methods for diagnosing children with Kawasaki disease, how we're working on developing a diagnostic test for Kawasaki disease, which I think is very crucial given the number of children that are missed or come to late diagnosis, as many of your own children have. Standard therapies that we give for Kawasaki disease, resistance to therapy, which many of your own children have suffered through, and what we're doing to try to overcome these issues. And then I'm going to speak a little bit about our clinical trial, which maybe even some of your own children have participated in, and we're eternally grateful for all of that. So this is a slide that I wanted to put up here, which I really don't need to for the families that are here, but I think it's important for all of us to remember what our own children went through with this disease, and that it is a clinical diagnosis. And what we're left with as physicians when Dr. Burns and I see your children in our clinics and in the hospital is really being able to diagnose and differentiate this disease from other diseases that may look like it. Oh, thank you. So it's clear that there may be other diseases such as viral infections that can cause you to have redness of the eyes that may be confusing, lymph node swelling of the neck that may be confused with bacterial infection, redness of the tongue that could be confused with scarlet fever, and rashes also that can be confused with both bacterial as well as viral illnesses. So the challenges that we face as physicians when we see children with Kawasaki disease is to be able to differentiate those that have KD from those that do not. What helps us in this process, and the reason that we draw blood on these children and on your children, is that we really want to look for inflammation. And here we have inflammation of the gallbladder that happens, of the liver, of all the cells in the body that really help us. And it's putting that picture together of the clinical diagnosis along with the laboratories to put that information together to help us diagnose kids with Kawasaki disease. Unfortunately, as many of you know, it's not a perfect picture. And in your own children, you may have had your own child present with fever and maybe only a couple of the clinical signs. So what I'm going to talk to you about today is a little bit about the developing of a diagnostic test. So I'm very grateful to the Robert Wood Johnson Foundation for recent funding that is effective January 1st of 2010. That is a 4-year grant that will allow us to develop a diagnostic test for this disease. And the way this works is that with the samples that your own children have been able to donate to us, we'll be taking information from the serum samples from children with Kawasaki disease, comparing that to kids that come to the emergency room that are febrile, may look like they have KD, but in fact they do not. And then what we call healthy controls, which are children that come into the hospital and have blood drawn for another reason. They may be having an elective surgery done. And with all of that put together, what we're looking for are biomarkers or proteins that are specific for acute Kawasaki disease to be able to develop this diagnostic test. And it's really with this funding from the Robert Wood Johnson Foundation in collaboration with biostatisticians that we'll be able to put this information together. Our goal eventually will be to have what we call a point of service test, a test just like doing a rapid strep in your pediatrician's office that will be available in pediatrician's offices as well as in emergency rooms, so that when the child comes in with fever and rash, and there's a concern that the fever's been going on for a few days, that they could potentially run this test and be able to see if there's a high likelihood for Kawasaki disease. So we're going to switch a little bit to the issue of therapy. As you all know, our standard therapy right now is high-dose intravenous immunoglobulin. And the reason we use this therapy is that it reduces the risk of coronary artery abnormalities from 25% to 3 to 5% if a child is treated in the first 10 days of illness. You also know that your children were treated with aspirin during their course of illness. Now, a particular interest of mine are children that have had Kawasaki disease and receive IVIG. Their fever may go down, but then their fever recurs. And this is called intravenous immunoglobulin resistance, or IVIG resistance. And the definition is based on the recognition that fever is a very sensitive indicator of persistent inflammation, and that it's recurrence of fever a few hours following the end of the IVIG infusion that really defines your child as having IVIG-resistant Kawasaki disease. And what's crucial to remember is that these children that have IVIG-resistant KD are at a higher likelihood of having coronary artery abnormalities. That's been shown by our group and others. So I've spoken to a few of you already this morning about this issue that we have here in San Diego and that we're seeing also in Japan and other places in the world with Kawasaki disease. I'll orient you to this slide. Here on the y-axis, you have the number of KD patients. Here we have years along the x-axis. The yellow bars are the number of patients that are responsive to IVIG, and the red bars are those that are IVIG resistant. And then you have the percentages. And if you look across the board here, up until about 2005, in San Diego County, we had an average of between 10 and 20% of our patients that were resistant to therapy. This has been the reported percentage that's happened worldwide. In 2006, what was frightening to us was that this red bar shot up to about 38%. And to this day, unfortunately, we don't know why this happened. We've had a number of investigations with even the pharmaceutical company that makes IVIG to try to figure out exactly what this was. Was it a difference in the way the product was made, a difference in the patient? None of those have panned out. But what we're left with, we have had the percentage of children that are resistant to therapy come back down over the last couple years, but it's still quite high in the 20% range. And our fear is that for some unknown reason, and because we don't know what causes KD, it's hard to determine exactly what it is, but for some unknown reason, there may be a group of children that are now more resistant to therapy than they used to be. And this has made us very interested here in trying to find additional therapies, both for children who are resistant to IVIG, but also, and I'll speak to you in a moment about our infliximab trial, to try to find additional therapies for all children with Kawasaki disease in order to prevent this percentage from rising any further. So what therapies do you have? And many of your own children may have received these additional therapies. We can always give a second dose of IVIG. I'll talk to you a little bit about infliximab in a moment. Steroids and cyclosporin. And these are all drugs that we use in children that are resistant to therapy and also those with coronary artery aneurysms that need to have the inflammation brought down. So what is infliximab and Remicade? So this is a TNF-alpha, it's tumor necrosis factor alpha here, is a molecule that's made by the body that promotes inflammation. And although it's by no means the only thing that's causing inflammation in our children with KD, it is certainly a major player. And as we unfortunately don't even know how IVIG works in our children with Kawasaki disease. We are working on that. But what we thought when we realized that tumor necrosis factor is an important inflammatory molecule in KD, we thought that when this was developed, which is infliximab, which is an antibody that attaches to circulating TNF-alpha, we thought that it may be an option for therapy. And if you look here, these little ovals represent TNF-alpha circulating in the body. These Y-shaped are the antibodies of the infliximab that attaches and takes this out of circulation. And by taking TNF-alpha out of circulation, it can't bind on cells and it can't start the inflammatory process from happening. So with this in mind, the first trial to address safety of infliximab in IVIG-resistant KD was started here a few years ago. And it was the first use of infliximab in infants in any disease, and it was the first trial of IVIG-resistant KD in patients with Kawasaki disease. And I'm happy to report that we recently published this, and we found no infusion reactions, no allergic reactions, and no serious adverse events that were attributed to the study drug. And in conclusion, with a single dose of infliximab, which is how we use this product, which is very different than how it's used for other adult and pediatric diseases, we found it to be safe in patients with Kawasaki disease. This is what's led us, with this information in mind, to be able to move on from there. And really the question that we had is in regards to this phrase, which is closing the barn door after the horse is bolted. The question we had was, is giving infliximab after the patient fails to respond to IVIG, is that like closing the barn door after the horse is bolted? Is it too little, too late? Should we be stopping the inflammation earlier on? Meaning when your child comes into the hospital, should we be giving them infliximab up front? And so we're currently studying that, and some of your own kids may have been in this trial that we just started in March of 2009. So this is a trial looking at the use of infliximab plus intravenous immunoglobulin. So everybody gets standard therapy with IVIG. Half of the children will be given infliximab, and half of them will get sugar water or placebo. I don't know, Dr. Burns doesn't know. The only people who know are the pharmacy as to who gets what. In 4 years, we'll be able to unblind the entire study and take a look to see who got what, to see if it makes a difference, both in inflammation and resistance to therapy, as well as in the coronary artery abnormalities. This is a trial that is supported by the Food and Drug Administration. We had funding from the Orphan Disease Grant, and it's the first of these awards to Rady Children's Hospital to support this kind of a treatment trial. So we have 2 centers. We have ours and Nationwide Children's in Ohio that are part of this. It's a 4-year study. 200 children with Kawasaki disease will be enrolled. And the goal really is to decrease the rate of resistance to initial treatment of Kawasaki disease. And I'm thrilled to say that as of 2 or 3 days ago, we've enrolled our 25th patient in this trial. So we're well on our way, having just started in March, to enrolling appropriately for this trial. So I just want to leave you with some quick thoughts and summarizing a little bit about diagnosing and treating KD. So far, in terms of what's going on in progress, we have development of a diagnostic test for Kawasaki disease and a clinical trial to improve the outcome of children with Kawasaki disease. But we certainly have several challenges that are still facing us. There's an increasing rate of IVIG resistant for unknown reasons, both here in San Diego and also reported in Japan. We have KD patients that continue to be misdiagnosed and treated late. And as a clinician, I have to say this is what really bothers me. Our children that are presenting to our outside facilities, even to our own emergency room at Rady Children's, and many of you may have experiences with your own children, that are seen over and over again with classic signs for KD and misdiagnosed. Or even worse yet, the ones that never come to clinical diagnoses with Kawasaki disease and are completely missed and present as young adults with other problems because of their coronary artery aneurysms. And clearly, finally, we need additional therapies for some patients who are very resistant to treatment. These are just goals that we're certainly going to be addressing over the next few years and hopefully being able to bring back to the hospital. Thank you for your attention.